Okay, now we're going to do chapter 60. I think it's 60. Maybe it's 61. Anyways, we're going to start our integumentary series, and that's going to, in the first chapter, which is either 60 or 61, I can't remember, we're going to talk about not all the skin disorders, but everything that's not including burns. And then the next lecture in the series is going to involve burns. So this first lecture is on just skin disorders, not really related to injury. And there are a million skin disorders that can occur. And the book has a lot of skin issues in it. If I don't mention it in this lecture, you don't need to worry about it, because there's some stuff that is really obscure. You're probably not going to see it unless you're working in a dermatology clinic or something. So I'm going to try to focus on the things that you're most likely to see in your nursing practice, and we'll talk about how to deal with it as a nurse. So the first thing I wanted to talk about is shingles. Shingles is really common, and you've probably seen it advertised on TV for there's a lot of medications and some treatments for shingles out now. So shingles is you can only get shingles if you've had chickenpox, and people get shingles because of a reactivation of a virus. So people who have actually had chickenpox, also known as the herpes zoster, if they've had that, and then they get over the chickenpox, the virus lays kind of dormant on the nerves. Well then, for whatever reason, and it typically happens later in life, so people age, because chickenpox is a more common in children, but then as a person ages, and for whatever reason, and typically it's just like if they get stressed, if they have another disorder going on, something that causes their body some stress, then the shingles virus can reappear. And it's really the same virus that caused the chickenpox, it's just in a different form. And it causes this shingles. And the defining characteristics is this rash, and the rash will usually show up in a certain band. It's very painful. It usually doesn't create too many problems other than the discomfort of it, unless it's around certain organs. Like if it's up near the eye, it can cause blindness and stuff. That gets a little bit scary. So if it's around certain organs, it's problematic, but otherwise it's really just annoying, and it lasts a long time. It can last up to a month. There are some treatments for it. Typically it goes away without any problems. The things that you would worry about is, if the person's scratching their fingers, have bacteria on it, can cause a secondary infection and things like that. But typically this is shingles, and caused by people who've previously had chickenpox. Now, as the population ages and children now have a chickenpox vaccine, less and less people are getting chickenpox, so shingles is probably going to be somewhat eradicated in this country as well. However, people, pretty much like 35 and older, 40 and older, they were not vaccinated with this, so you're going to continue to see this for a while as the population ages. So you can't catch it. It's not like chickenpox is very contagious. It's not that level of contagion. However, if somebody comes into the hospital and they have an open shingles rash, you don't want to put them with other patients, because if this has open or like oozing in it, and somebody else, another patient who's already under stress or in the hospital for other reason, you can catch it. You can. It's not as contagious, but if somebody rubs up against that and they have an open sore, then they can get it that way. So you do need to be a little bit careful if you have a patient that has this. So that's shingles, pretty common, one of the skin disorders. The next thing I wanted to talk about is impetigo. Impetigo, you'll probably talk about more when you are in your pediatric rotation. This is very common in children. It can occur at any age, but it's really common in children. And impetigo is basically just an infection in the skin. It's caused by Staphylococcus and strep. Those are the two bacterias. And typically what happens is like a kid will have like a mosquito bite, a scratch, a burn or something, and they'll itch it, and then they'll introduce the bacteria into the open skin. And what you see with impetigo is this honey, yellow, crusty kind of scaly stuff. It often occurs around the mouth or the nose because a kid will maybe have like a cold or something. They're constantly doing this. Their hands are not clean, and then they'll get an opening in their skin, and it will lead to this impetigo. It's a little unsightly to look at, but it's really not that big of a deal. It is contagious, so you do, if you recognize this in a kid, you do need to isolate them, like you'd have them not go to school and things like that. But the treatment is an antibiotic because it's just either staph or strep. But we know that both of those are treated with antibiotics. So you put the kid on just an oral antibiotic, and typically they're fine. They're not a big deal. It's usually gone within a week. So this is something that you're going to see more in maybe like indigent populations that where good oral hygiene, hand hygiene isn't well established or not well practiced. You're going to see this showing up. But again, of all the skin disorders, it's common but easily treated if you can get the antibiotics that the person needs. So the next thing I want to talk about is psoriasis. Psoriasis is another very common skin disorder. There's a lot of commercials out now for medications to treat psoriasis. There are a lot more effective and better treatments now that have been coming out in the last couple of years. The classic thing with psoriasis is they have these red patches, and in the middle of these patches are like these silver scaly things. You will often see psoriasis like back in the hairline in here and on elbows and knees. And basically what happens with psoriasis is the skin is multiplying too quickly. And so over here I have a picture. This is what a normal skin should look like, and this is a skin that has psoriasis, where this top layer is just growing way too fast and then develops these silver scales on it. This is a little bit harder to treat because it's not caused by a bacteria or something. People that have psoriasis, they usually battle it their whole life. They're often on steroids, and a lot of steroid creams that they use now can help diminish this. Psoriasis, people that have psoriasis, they tend to, it gets worse and then it'll get better, it gets worse and gets better. It tends to get worse in situations where the patient might be a little bit emotionally stressed or have some kind of physical ailment going on where their body is also fighting off something else. Then the psoriasis will kick in. It can affect joints. It's not as common, but people who have psoriasis can get psoriasis affected arthritis in the joints. But typically it's just treated with topical creams or oral steroids. So this is really common. It's not contagious, not at all, but it is unsightly. So your patients who are dealing with this will have a lot of self-image problems, maybe some isolation problems. People don't want to go out in public when they have this condition because it's unsightly, but it's not contagious. And it can be painful, but it's not really itchy either, so it's just more of an annoying nuisance problem. So read about psoriasis, very common. I'm sure you're going to deal with that in your practice. You're going to see somebody that has psoriasis. The other thing that is really common that we deal with all the time in nursing is wounds in skin. Typically, the standard is if the wound is dry, you put a wet dressing on it. If the wound is wet, you put a dry dressing on it. But in most of the hospitals and places where you work, there will be a wound ostomy nurse. Some of you guys may end up wanting to specialize in wounds and ostomies. And what wound ostomy nurses do, they're usually called WONs, the wound ostomy nurse. They are experts in managing wounds, and they will come in and assess a wound and figure out what kind of dressing to put on. If you are new at nursing, or you're working in a place that doesn't have a woundoscopy nurse, you're waiting for the dermatologist or who's ever managing this wound to come in, it's the best treatment of choice if you don't have what am I trying to say? So an order, like for a certain kind of a dressing. The treatment of choice really is a moist, sterile, saline-soaked gauze. And the reason that you want to keep a saline-soaked gauze on most wounds is just to keep the wound wet. If you keep the wound wet from not drying out, then what you want is you want the wound to granulate in and up. See this wound here, see how this one is kind of going down inside there? That's not ideal, because you don't want this to close up and then have that pocket in there that has not already granulated up. So what you would do with a wound like this is you would get your sterile saline soaked gauze and you'd pack it down in there, and what that does is that it will help the healing granulating tissue come up this way. And so the very last thing to close would be right up here, and that's how you'd want those wounds to heal. This wound, actually, it's a little bit, you've got a little bit of yellow exudate right around here. That's probably not super painful. And actually this red healthy is actually healthy tissue. You just don't want that to close off before it's granulated in. Over here, the edges of this wound, it's not well approximated. By well approximated, I mean coming close together. For example, this wound, which is obviously a surgical wound, you would call it well approximated, meaning you can see how the incision, which is right up in here, like there's certain spots, like right in here, you can't even see where the cut was. That's well approximated. This one is. It's not well approximated. The edges are jagged. It doesn't look horrible. It's not black and blue. There's not exudate around here. You've got this white stuff in here, some nice granulating tissue in here. You would just, again, cover this with a moist gauze dressing on it, because you don't want other bacteria to get in there. And then you would just change that several times a day. The other thing about when you put a wet gauze on a wound is that when you take it off, you go to change that gauze, it will pull some of the dead cells out with it, and then you put a fresh wet dressing on there, and so the granulation can continue and you're removing some of those dead tissues. This wound here is, like I said earlier, a surgical wound. Now, in the normal healing process that we talked about a couple weeks ago, it is completely normal to have areas of redness and slight swelling, usually within 24 to 72 hours after surgery. That's normal. That's part of the normal healing process. You will expect, if there's an injury, you're going to have some redness, warmth, things like that, because the body is trying to heal itself. Now, I would start getting a little bit nervous about the bold redness of this. Because these stitches are still in, I'm guessing this wound is probably, and it's well approximated, so you can tell that this wound is probably 10 days old, maybe 14 days old. This should not be that red. So I might start getting a little bit nervous about this. However, the incision is still well approximated, so I'm not as nervous that there's something going on underneath the skin, because if there's an infection underneath the skin, you would probably see pieces of this incision opening up. So I would probably just watch that. I would monitor this patient's temperature, maybe grab their white blood cell counts, and maybe just keep this washed with some warm soapy water and maybe a little bit of topical antibiotic ointment, and just keep an eye on it. If it started to open up, then you get another problem. Then you'd have something more like an open wound that now we're packing in, and your wound has dehisced, meaning opened up, and then we're going to start putting a wet to dry dressing in there. So these are just, ulcers and wounds are probably by far the biggest skin problem that you're going to take care of as a nurse, because tons of patients, decubitus ulcers are still a ginormous problem in the hospital, even though we're doing all kinds of things to try to prevent decubitus ulcers from happening. You're going to get patients in from the nursing homes, you're going to get spinal cord injury patients, and they all have decubitus ulcers. So this is a huge skin component that you're going to be dealing with as a nurse. Okay, so read up about those. The next thing I wanted to talk about is some of the skin cancers. Some of the skin cancers are no big deal. Other ones can be extremely deadly. It is important to understand what some of these different ones look like. It is really important when you're doing your head-to-toe assessment that you're doing a really good skin assessment, because you're going to want to identify some of these things. There is a marked difference between just a normal mole, something that is an expected pigmentation in the skin, and something that is not. One thing that you look for when you're identifying a cancer is irregular borders. And you'll notice with each one of these, see in the squamous cell, see how the borders are irregular, and this basal cell is a little bit more circular usually. However, classic with basal cell is this waxy, clear border on it. It's a basal cell carcinoma will be raised, and it will have like this translucent, waxy border. That is not normal in a typical mole. Squamous cell is also raised, but it just looks ugly and nasty. And with melanoma is typically flat. It's more tan and brownish, but see how, again, the borders are irregular? I don't know if this is normal or not. This could be also be the beginning of a melanoma. It's a little bit darker than a normal mole and just slightly irregular. I'm trying to see if anybody on here has a decent mole we can look at. All right, I don't see one, but I'm sure you guys, you have a mole somewhere that you can look at, you know, or just like some discoloration in the skin. I guess I don't have any I can show you. But a normal mole should just have like nice round edges like that, and all the same color. They can be raised or flat, but they're really consistent, really normal looking. If you are taking care of a patient long term, like if you're working in a nursing home or something, it's important to just, or if you're working in a clinic, you're doing like yearly physical exams, it's just important to note what moles are present and do they look the same the subsequent year. So the squamous cell, these kinds of cancers, they are often seen on the face or areas that are exposed to the sun, like construction workers who haven't put good sunblock on top of their ears can get it on top of their ears, their nose, their cheeks. So your patients who have been sunbathers, who have not used good sunblock, and you have to teach your patient to use sunblock. Even on cloudy days, those UV lights that come through that can cause the skin cell to switch over and start developing a squamous cell carcinoma. So when you're doing your safety teaching with all of your patients, you make sure that they are using their sunblock almost daily, especially if you're working with clients who are outside a lot. What was I going to tell you next? Okay, so I told you about the basal cells, and then the melanoma. The melanomas, here's the situation with melanoma. When the melanoma is first identified, they can usually excise it, and by that I mean like they'll do with all of these, the treatment of choice is called a radical excision. And by that I mean the surgeon will go in and they will, by radical, I mean they will take a section like this, and they will send it, during surgery, they will send it to the pathologist. And in pathology, the pathologist will like start looking at these borders, and he will get, or she will get a section until they have clean margins. And they will do that depth-wise too. That's called a radical excision. And in most types of skin cancer, that's all you need. And so they will just radically excise this, and then they'll watch it. Sometimes, depending on like how much it's spread, like for example, if this is also a melanoma here and it's starting to spread, they might want to also radiate the area. But most of the time, you don't have to do chemotherapy because it's not in the lymph system. So once it's identified, they can just excise it. That's the treatment of choice. The other one that we talked about during our HIV week is Kaposi sarcoma. Kaposi, I should have put a picture up here, but it was in one of those previous lectures that I did. Kaposi sarcoma is more of that big, large, purpley blotches. They typically don't radically excise Kaposi sarcoma because that usually shows up in patients who have HIV or AIDS, and that's just like a complication of that. So they typically don't excise those like they do with these kinds of cancers. Of these three cancers, this one is the most deadly. They will, once it's identified, they will take it out surgically. The problem with melanoma, it's called the silent killer. They can take it out and the person is just absolutely fine for years, like 20 or 30 years, and then all of a sudden it will come back with a vengeance. When melanoma reoccurs, it is, the likelihood of survival is very, very slim. At first, if they first take it out, the chance of survival is excellent, 20 or 30 years, and then you just pray that it never comes back, because if it does, then it is extremely deadly. And most of these have fairly good prognosis if they catch it early. If they don't catch it early and it starts metastasizing, then it can be a little bit more complicated. So that's with the cancers, and that's it. That's all I have. So those are the things I want you to study this week. I want you to study pressure ulcers and wounds, the different kinds of cancers and how to treat it, what that means for the nurse, impetigo, psoriasis, and shingles. Those are really like the 5 big things. When you get to peds, you'll do some other things like chicken pox and stuff like that, but that's it for this part. And then in the next lecture we'll talk a little bit about burns and how to take care of patients who have been burned. But as far as chapter 61 goes, that's it.